Good afternoon, everyone. Oh, come on. I think a good majority of this room has just taken a White House tour, which is very cool. So good afternoon, everyone. Good afternoon. Excellent. Well, thank you for coming. First and foremost, welcome to the White House. Welcome to our day on cardiovascular health here at the White House. We are just so thrilled to host all of you here for the morning on the tour and then today for our next iteration of our Making Healthcare Better series on cardiovascular health. We couldn't be more thrilled to host you, and I just cannot go any further without thanking two very important people that have made this day possible, and that is Susan Campbell with Women's Heart and Sue Nelson from the American Heart and Stroke Association. So let's give them a round of applause. There has been a lot of thought and effort that has gone into this for the last many months, actually, to make sure that this day was a really special day where we celebrated the accomplishments that the administration has made over the last 7.5 years, but more importantly, that we celebrate the accomplishments that each one of you as advocates for cardiovascular health have made in your community. So we're just absolutely thrilled that you're here. We have an absolutely packed day, and I want to remind folks of a few things. First, this is a live streamed event, so we have friends and family of folks in the audience, folks on our panels that are watching from home. So I'd like everyone to take out their cell phones and put their phones on silent. As much as we would like to hear your Taylor Swift ringtone, we want to make sure that all of our friends and family at home can hear everything that's going on in the important conversations that we're having in this room. The next is that we'll have 3 panels today, as you can see on your agenda. And during each one of those panels, we'll have question and answer time, and we'll want to make sure that the entire audience has an opportunity to ask questions if they've got them. We might not be able to take all questions, but we want to make sure that this is an organic and thoughtful conversation with everyone in the room, not just to everyone in the room. A few things that I'm legally required to say: exits in the back of the room and in the front of the room here. And restrooms. I know that that is always the number one question. Right outside this door, ladies, you'll take a right and then a right, and it's the first door on the left. Gentlemen, you'll take a left, and it's the last door on the right. So ladies, right, left. Gentlemen, left, right. So without further ado, I am just absolutely thrilled to introduce our first speaker, who is the president of the American Heart and Stroke Association, Dr. Stephen Hauser.
Wow. I thought there'd be just a few folks here for me to chat with. Thanks for all of you for being here. It's a hot day. Feel free to take your coats off if you need to. So good afternoon. I just have a few prepared comments to give to you. I want to thank you for joining us here today. I'm Stephen Hauser. I speak to you today on behalf of the HA, for whom I've been a volunteer since I received my first grant in 1979. I'm currently serving as AHA president. In my day job at Temple University School of Medicine, I serve as the Senior Associate Dean of Research, the chair of the Department of Physiology, and the director of the Cardiovascular Research Center, where for the last 35 years I've studied the mechanisms of ischemic heart disease and cardiac repair. It's a privilege to be here today, be with you as we gather to focus on the critical topic of cardiovascular disease, which, as all of you in this room know, is the leading cause of death, not only in the U.S., but across the world. It's an honor to be in the company of so many distinguished guests and thought leaders in this field. We've all shared the same commitment to advancing cardiovascular science and healthcare. The reason today's gathering is possible is because of the outstanding leadership of President and First Lady Obama and the entire administration, who have shown unwavering dedication to improving and saving lives of all who face cardiovascular disease. The vision of the Obama administration brought us the Affordable Care Act, and as a result, already 20 million people who were previously uninsured have gained access to insurance coverage, including more than 7 million Americans with cardiovascular disease or with significant cardiovascular disease risk factors. I'm sure many of you have heard recent reports that in the first quarter of this year, the uninsured rate fell below 9% for the first time ever, dropping all the way to 8.6%. Under this administration's leadership, we saw the passage of the Family Smoking Prevention and Tobacco Control Act, landmark legislation that gave the FDA authority to regulate the manufacturing, distribution, and marketing of tobacco products. The administration's focus on healthy eating and physical activity has been unparalleled with the First Lady's Let's Move campaign. The release of the 2010 and 2015 dietary guidelines for Americans, updating nutrition standards for school meals, revisions to nutrition facts panels, and most recently, the development of voluntary sodium reduction targets, all really great things for the American population. The administration brought multiple stakeholders together to create the Million Hearts Initiative, an unprecedented partnership between the public and private sectors to prevent 1 million heart attacks and strokes. I am proud to say that the AHA is a member organization. And earlier this year, close to my heart, Dr. Gibbons' heart, we saw a $2 billion increase signed into law for the National Institute of Health, the largest regular appropriation increase since 2003. I encourage all of you to see the administration's new report, which was issued just today, which takes an in-depth look at the progress being made against cardiovascular disease in our great nation. I have devoted my entire career to cardiovascular disease research and to find meaningful solutions that change patients' lives. Words cannot describe how much it means to know how deeply this administration cares and how determined they are to provide support in every way they can. So once again, thanks so much to the President and First Lady and to all of you. And now it's my honor and privilege to introduce the Director of the Centers for Disease Control and Prevention, Dr. Thomas Frieden. Dr. Frieden has been the CDC Director since 2009 and previously was Commissioner of the New York City Department of Health and Mental Hygiene. He is the well-deserved recipient of numerous awards and accolades and has been included in Time Magazine's list of the world's 100 most influential people. Please join me in welcoming Dr. Thomas Frieden.
Thanks very much, Steve, and thanks so much to all of you for everything that you do to prevent heart attacks, strokes, and cardiovascular disease all year round. As we all know, heart disease and stroke and other cardiovascular disease are the #1 killer in America, 800,000 deaths a year. It's a stunning, it's almost an unfathomable number. To bring it down to specifics, that means 2,200 people dying every day, 1 every 40 seconds. It is the #1 killer of both men and women. It is the #1 killer for everyone over the age of 45 in this country. More than 85 million Americans are living with some form of cardiovascular disease. Direct and indirect costs beyond the human costs are more than $320 billion a year, or $36 million an hour. And beyond the numbers, beyond the dollars, I believe that everyone here has been touched at some level by heart disease, stroke, and other cardiovascular disease. Not only is it the #1 killer in America, but less well recognized is the leading cause of health disparities between black and white Americans. It is the single greatest cause of the difference in life expectancy. There is also a disproportionately high rate of cardiovascular disease among American Indians and Alaskan Natives. And this isn't unique to the US. Globally, tobacco is the only thing that, globally, hypertension is the only thing that kills more people than tobacco around the world. It causes about 1 in 3 deaths, and we're seeing a continued increase in deaths around the world. In fact, 80% of deaths from cardiovascular disease are in low and middle income countries, and it is woefully neglected in terms of both prevention and treatment around the world, with control rates down in the 15% rate for much of the world. Beyond that, and what makes it all the more tragic, is that much of cardiovascular disease is preventable with tools that we have today. Interventions that can be done in communities, in healthcare settings by patients and families could prevent many and perhaps most of the cardiovascular events and deaths that occur each year. There has been progress. There's been progress in overall health for Americans. There's been progress increasing access. It is extremely important that 20 million more people have access to health insurance, have health insurance. We know from studies that CDC has done that control of blood pressure is higher in people who have health insurance. So this is literally something that will save lives. We also know that the proportion of Americans smoking has fallen to historically low levels, down to 15.2% in 2015. And through the Million Hearts Initiative, which you heard announced earlier or mentioned earlier, more and more Americans are learning of their blood pressure, their other critical vital signs, and taking steps to prevent heart attacks and strokes. But we're not doing nearly enough. There's much more to be done. If we think about where we are versus where we may be, the American Heart Association, which we're delighted to have as a key partner here, has produced trend analyses that are sobering. If current trends continue, nearly half, 44% of the U.S. population will have some form of cardiovascular disease by the year 2030. If current trends continue, total costs will rise to nearly $1 trillion a year. That's more than $2.5 billion a day, a difficult number to even conceive of. And we're fighting some temporal trends which are challenging. If we look at what's happened with adult obesity in the United States, the gold standard studies done by CDC and Haynes show that obesity has increased from 23% to 35% by 2012. So a substantial increase in obesity, and of course following that has been a substantial increase, in fact a doubling of diabetes. So as the Red Queen said to Alice, we have to run faster and faster just to stay in place. In order to maintain the pace of reductions in cardiovascular disease, we have to accelerate the intervention of prevention programs. Now, we also have to be particularly mindful of the impact of cardiovascular disease on health disparities. African Americans are much more likely to have hypertension and less likely to have it controlled. We have to ensure that not only do we address something that affects all Americans, but we bring everyone up to the same high level of control, high level of health as rapidly as possible. There are also major geographic disparities. CDC is based in Atlanta, part of what we refer to as the stroke belt. And if you look at southern states, you see a much higher observed stroke and heart disease mortality than you would get from just the basic risk factors. And we're teasing out what some of that is about, but we know that the cascade of cardiovascular prevention needs to get better at every step, from prevention in the community to recognition to treatment to control. The Affordable Care Act ensures that evidence-based screening and treatment are available and affordable, and with support from the White House at CDC, we've been able to launch a series of cardiovascular prevention programs, including the Million Hearts program, which we've done in collaboration with CMS and more than 130 federal and private sector partners nationwide. This is an ambitious program which said, in 5 years, let's try to prevent 1 million heart attacks and strokes. In the community, the goal has been a 10% reduction in smoking prevalence, a 20% reduction in sodium intake, and the elimination of artificial trans fat. In the healthcare system, substantial improvements in the ABCs, use of aspirin, control of blood pressure, management of cholesterol, and smoking cessation efforts, ABCS. And if you see how we've done, there has been real progress. There are now at least 5 million fewer smokers than there were when President Obama took office, and that's a remarkable achievement. There is a slight increase in the control of blood pressure. In fact, the proportion increase is about 11%, relative increase from about 49% to about 54%. It's been going up by about a percentage point a year. We need that to increase to about 5 percentage points a year. But parts of the U.S. and healthcare systems around the U.S. are showing that it's possible, are showing that if you focus on effective management of a chronic condition, you can get the vast majority of your patients adequately and effectively treated. Through Million Hearts, we've recognized Million Hearts champions that have gotten to more than 70% control rates in large practices, small practices, independent practices, urban areas, rural areas, through a wide variety of models, but all of them have certain key characteristics, including getting all members of the healthcare team involved, reducing barriers to treatment by the patients, including financial barriers, ensuring that there are protocols in place to follow. And this kind of improvement in the quality of healthcare is going to be a pathfinder for all areas of healthcare, because first and foremost, we have to prevent cardiovascular events. This is the leading cause of death, the leading cause of health disparity. But what we learn in doing that will be enormously important in every aspect of healthcare to improve the quality and the performance of our healthcare system, to which now tens of millions of more Americans have access. Finally, I would just like to say that there is so much more to be done. Our work is so far from over. It's useful to take stock and say, yes, we've made substantial progress. Yes, there are millions fewer Americans smoking, millions more Americans whose blood pressure is controlled. We've eliminated or are well on the way to eliminating artificial trans fat from our food supply. The FDA action earlier this year with sodium sets on a path to steady reduction in sodium, which will put choice into consumer hands so that people have control over how much sodium they consume. Today, they don't, because there's so much in our processed and restaurant food. We need to work together both in the community and in clinical settings to do more, to remember that each day, each second, there are deaths that could be prevented from cardiovascular disease, and working together, we can not only build on past successes, but further accelerate. So thank you so much for everything that all of you do.
Now, I know that this has just been an incredibly filled afternoon of information and storytelling, and we are just so thrilled that we are able to be closed this afternoon by Dr. Rob Califf. And to introduce him, we are so thrilled to be joined by Alvin Rouse, who is a retired partner at Deloitte and involved with the American Heart Association. So we'll bring him up now.
Thank you. Well, good afternoon. I'm Al Royce. I'm the chairman of the American Heart Association, and it's my great honor this afternoon to wrap this day up. It's been an amazing day with a lot of great stories, as has been said. A couple logistical matters. Before we finish, could you please stay in your seats? We want to get a group photo. You all look so good in all your red. And I'd also like to, again, thank the White House for co-hosting this event, and in particular, Bess Evans and Vidor Sharma for hosting this event with the American Heart Association. This has been a terrific way of celebrating the progress that has been made under this administration in our fight against cardiovascular disease and stroke, and to begin to chart a course for the next 4 years. And I'd like you all to give yourself a round of applause. Thanks for helping do this. Now, it's my honor today to introduce today's final speaker, Dr. Robert Califf, Commissioner of the U.S. Food and Drug Administration. Dr. Califf is recognized worldwide as a leading cardiologist and researcher, and I'm proud to say he's also a longtime fellow and associate of the American Heart Association and a volunteer. Before joining the Food and Drug Administration, Dr. Califf was a professor of medicine and the founding director of the prestigious Duke University Clinical Research Institute, home for the world's largest and oldest institutional cardiovascular disease database. So, Dr. Califf, without further ado, welcome.
Thanks so much. How do you close a day like today? Really amazing, wasn't it? This is usually where you make the joke about, I know I'm standing between you and a drink or the airport or whatever it is, but I suspect many of you are not looking forward to emerging back out into the Washington weather. Still, I'm going to keep it short and hopefully sweet. And as I was sitting here today and also just walking in, it was amazing to see so many old friends. I mean, what a network of people that have accomplished so much over the years. Some of you are as old as I am. I was proud, actually. I had dinner with Andy Slavitt last night, the head of CMS, and I told him, you know, I was amazed you let me into your club. I got into Medicare this week. I actually applied online, and they sent back and said you were accepted. I was feeling I was a member of a prestigious club at that point. But when I started, thinking I wanted to become a cardiologist. It was 1973. I was an orderly in a hospital. At that time, orderlies mostly emptied bad pans and put in Foley catheters. Foley catheter, a really important skill as I'm getting older. I need to know about that. But I saw a person die in the emergency room and get a shock and come back to life. And I thought, holy smokes, this is something I really want to be part of. I want to do it. And so I went on to medical school and a fellowship in cardiology. But many of you were around at the time and remember in the late 1970s, we were really at the peak of heart disease death. People died in their 40s, 50s, 60s, mostly of sudden death. As I started as a CCU director, our treatments were basically Lasix, morphine, and prayer. We didn't know what caused heart attacks, amazingly enough. When I tell interns about this today, it's like, how could you not know what causes a heart attack? It's so straightforward. But just think about what's happened since that time. The rate of death has been cut in half. If you make it to a hospital alive with a heart attack, your risk of dying with that acute problem is cut in half. But of course, the big advances have been in prevention, and we're seeing the effects of that. But to quote a mentor of mine, which I think explains why we still have a lot of work to do and why we're still here, what we're doing is helping people live a lot longer. Eventually, though, things happen. Or the quote was, life is a sexually transmitted disease with 100% mortality. So if you think of it that way, eventually something is going to happen, and to a large extent, it's been heart disease that has been the final event for people. And so just a quick run through things I've heard today that I found amazing and really exciting. I mean, the basis of all this, of course, is prevention. We've heard that over and over. And we sort of have to go back to the basics of prevention. It's food, tobacco, exercise, information. And I think the discussion that we just finished reiterated what a lot of people said. It's community engagement, but not just community engagement. It's community engagement increasingly with good evidence and good measurement of what we're doing. I heard that over and over during the course of the day. And I think it's critical that given the tools that we have today, we go beyond wishing that things were better or having ideas about how things could be better, but actually implementing and measuring. And we know at the FDA, for reasons I'll tell you in a minute, that we'll get it wrong a good bit of the time. But if we measure things, we'll know when we get it wrong, and we can adjust our course and get it better. The second area, of course, is treatment. And we heard about drugs today. It was exciting. Chris, you and I have a lot to talk about because, and I hope I get a chance to do it, because when the president offered me the job, which is kind of, you go into the Oval Office, you're kind of shaking. What did he want to talk about? How much he hates Duke basketball, and I'm a Duke guy. I don't know what you taught him. He's very competitive. After 10 minutes of being told I was cheering for the wrong team, we were both high school basketball players and reminiscing. He got onto the business of what this is all about. But I also had the privilege of coordinating the big trial of TPA for heart attacks in the early 1990s. Many of you actually were part of that, and I remember your participation. As much as it was about the drug, it was really about building a community on a global basis that had decided it was going to do something about heart attacks, and not only do one trial, but then the whole community went on and reeled off clinical trial after clinical trial. And a real lesson that's still true today is that most of what we tried didn't work. We have short memories. We forget about all the things that didn't work. But even today, with all the discussion about targeted therapies in areas like cancer, over 90% of drugs that get into phase 1 don't get to market because they don't work, or there's a toxicity that was unexpected. And unless we continue to do a better and better job, what so many of you talked about, which is participate, volunteer, not just in raising money, which is critical, but actually volunteer to participate in the studies. Because we frankly, no matter how good our science is, don't know whether something works until we try it out in real live human beings. And that is a tough business that requires really dedicated people. I had the chance to meet with women today at HHS. And I will note that in general, a lot of the discussion today has been about the value of women in many ways And I think it's still empirically true that men basically will do what women tell them to do. And so I think the key to volunteerism here for participation is women taking it on, and your men will go along with it, maybe grudgingly, but it will happen. We heard a little bit about biologics today, and I want to just emphasize this area. We are learning so much about human biology right now. It's just astounding. And I'm going to, at the end, tell you just about one area of it that I find amazingly exciting, not because of the topic itself, but because of the window it opens up to what we can do if we work together. And of course, we can't forget devices. Several of you have brought up devices. If you ask me, devices are the most underappreciated part of the medical armamentarium, other than prevention, which I agree with what everyone said. It's harder to think palpably about prevention. But in heart disease, so many people are dependent on pacemakers, defibrillators, or simple devices that just measure blood pressure. You don't think about that all that often, but there's a lot of work that goes into making that work well. And I'll add, a tie between devices and prevention is the amazing ability we have that was unimaginable 5 years ago, that we can measure blood pressure 24/7. The technology's here. It's going to be happening, and it can be computed and kept in the cloud, and there's no limitation to our ability to store the data. And it can be income agnostic. That is, almost everyone in America has a cell phone. It's really a computer more powerful than what we had on our desktops 5 years ago. So that means we can disseminate this technology in a way that can give people personal feedback that will enable them to take better care of themselves and for communities to do the same thing. So just a quick word about the future as I'm seeing it. And it is a really amazing privilege to be commissioner of FDA. Yes, we get attacked every day, and I can get up every morning. I get a feed from the paper of all the people that have said bad things about me personally. That actually does happen. But I get to see all technology essentially that's going to be used for human health, and it's just an astounding time. And I'm going to go through this quickly. Precision medicine really is here. And it's been an amazing thrill to work for a president who really gets it. Some of you have been in meetings with the president. When you talk genetics, genomics, healthcare delivery, with this guy, he understands it better than a lot of scientists that I'm with. I was in a room with him one time having to explain why the FDA was not going to be a block to whole genome sequencing. And I had my speech all prepared. They said I had 5 minutes to convince him the FDA was not going to do a bad job of this. And I was going through 3 billion base pairs, an error rate of just 1%. And before I could even say it, he said 30 to 60,000 errors per patient, per test. He had done the math. It's just astounding. So precision medicine is here. It's happening. And when the call comes out shortly for volunteers for the Precision Medicine Initiative, which will be a cohort open to all Americans, I hope you'll all volunteer, and you'll advise that your friends and colleagues also volunteer. We do need people who volunteer also who are savvy like you are and know that when something initially rolls out, it's going to have kinkiness. Everything's not going to work. But to get it to work for the average person that you're so concerned about, we need a lot of people to participate and help us develop the best system possible. And this is open for everyone in America eventually with the goal of bringing together electronic health records. To call out some special populations I've heard about that I am very concerned about for different reasons. Pregnancy. Several of you have brought up this issue. The fact is we know very little about therapeutics in pregnancy. And thanks to the work many of you have done, we have a whole class of Americans who didn't exist before who survive with congenital heart disease and then get pregnant themselves. And I can talk about this because my daughter is in that category. She's now 38 years old after major congenital heart disease surgery at age 4 months. But I'll have to say, as commissioner of FDA, when I look at the labels for the drugs that patients need to take when they're pregnant, almost none of them have been tested in pregnant women. This is a hard area. You talk about volunteerism. You got a baby and a mother at the same time. But we won't know what to do. We won't get it right unless we figure out how to do the studies, and I think you all can help with that. That brought me to congenital heart disease. I think it has been a little under-discussed. Several of you have brought it up, but 1% of people in the world are born with congenital heart disease. They're mostly surviving now. And so as we think about this in cardiovascular disease, in addition to the big dominant diseases that we hear about, things like hypertrophic cardiomyopathy, valvular, and other types of congenital heart disease, very important. The elderly. Do we know the right dose of any drug for someone over age 80? I don't think we do. And that's the fastest growing part of the population. I'm getting close to that, so I'd like to know the answers. But it's very possible to do the studies, and I think we really need to do it. And then disparities in general, and I think delivery disparities are really at the forefront now. And whereas before we could sort of talk about it, I'll just emphasize again, we have the technology now to measure it in real time. And my hats are off really to other parts of HHS for putting together systems that we now have that can do this, but we got to learn how to use those systems in a way that also respects the dignity and the privacy of individuals as we put these quality improvement systems into place. I just think they're absolutely critical. A shout out to African American men. Gary, you're here sitting next to you. I've heard a lot about African American women. If I had to pick one group of people right now who are dying at just an unacceptable fast rate, this is the group. And I think we've got to really work together to figure out what to do about this. And I won't go into detail, but I think you all would probably agree with me. We just need to acknowledge it. And then finally, just a couple of things to mention that I think are critical for the future as I look at it. The first is, I just call it evidence generation. And I'm just really excited that many of you are able to tell with stories the importance of knowing what we're doing by volunteering so that you produce data that's turned into information that can be used so that we steer our treatments to the right people at the right time. That's what precision medicine is all about. And there was a myth a few years back that with precision medicine we wouldn't need so many volunteers because we could just figure it out in a little segment of people and then apply it to everybody. Well, I think the lesson which the president has fully absorbed, and now it's kind of fun to watch the vice president absorbing the same message as it relates to cancer. The real answer is we need a lot more volunteers because to understand what to do with every subsection of people, we need to look across a broad population of people and see what different people have in common and then design our treatment. So we need you to volunteer. We need you to encourage others to do it and to help us figure out how to judiciously and appropriately deal with all the data we now have. We have a surplus of data and a deficit of knowing exactly what to do with it. And then I'm going to go to one area of technology just to pique your imagination, but also to emphasize the critical importance of meetings like this and discussions like this, because who knows how we should handle this amazing opportunity. I've been briefed in the last 2 weeks about gene editing. How many of you know what gene editing is? Okay, so most of you. That's great. I sort of thought I knew what it was, but I've been briefed by the group at the FDA that deals with plants, the group that deals with animals, and the group that deals with humans and therapeutics. So, as you know, with gene editing now, a high school student at a high school science fair, and this is happening, can either add to the genome, can substitute for a gene, or can delete a gene. It's entirely possible. The kits are costing, I'm told, about $300 now. Now, you have to have access to all sorts of other technology to do it, but high school students can program, so they can do this stuff. But think about the nutritional issues that we've talked about. The opportunity is if we can produce plants that are very low cost, that don't perish on the way from the farm to the table, which is, the problem in places like India, and a big problem in places that have food deserts. We could produce very inexpensive food, very nutritious, and beat the socks off of candy bars and various other things like that. On the other hand, it's impossible to actually know when a plant has been gene edited. You can't figure it out. And so there's a possibility for harm to be done with this if it's not properly handled by the community. And of course, much of society is very concerned about anything that says genetic manipulation of food. So there's one part, tremendous opportunity, many issues we have to deal with. Then we go to animals. So you want cattle that are twice as big. You want to get rid of, have lean beef. You want chickens producing more eggs. I don't think there's going to be a limitation on being able to do this, because once you understand, this is really an extrapolation from the, knowing the genetics to now understanding the functional significance of genes, and now being able to make those manipulations. Or you have a rare genetic disease for which there's no animal model, which is almost every. You know, how many diseases have we cured in rats and mice? It usually doesn't work in humans, as I said, over 90% of the time. And the reason is because we're different. But if you can insert a human gene into an animal, there's going to be a whole different approach to developing animal models of human disease, so you can try out the therapies and figure if they work. Well, there are a host of issues with that too. It's an opportunity, but we don't know what to do. Well, now we are getting applications for gene editing in humans. They're beginning to come. They're in-house. There are many societal views on this, but it's definitely going to be feasible to substitute a gene for issues like sickle cell disease, which are just terrible problems now, very difficult to deal with. We have many partway solutions that can be helpful, and we shouldn't stop on that. But the question before us is, how should we employ these technologies? What should the rules be? When is it okay? How do we regulate it? And how do we realize the opportunity in a responsible way? And so I'm just here to say that this is not a problem that scientists are going to solve. The science, in my view, is sort of done. I mean, it's going to continue to go. There's a lot more to learn. We'll get better and better. But the real questions have to be resolved by groups like this, where people from all different walks of life and cultures get together and think about the future and understand each other, and then help people that make policy understand what to do. So in conclusion, I'd say one lesson I've definitely learned at the FDA is that areas of health and disease that have very effective advocacy do better than areas that don't. And the advocacy is not just someone pounding on the door like the old days of advocacy. It's really creating an ecosystem which is built on understanding the disease that we're trying to fix, understanding how people get involved in helping themselves, and understanding how to create the information that we need so that out of all the science out there, most of which is not going to work in human therapeutics, we pick the things that do work and then apply them in the best possible way. And I leave today very optimistic that this is a group that can and will lead the way. And thanks for giving me a chance to be here today, and have a great weekend.